So the topic is cornea. In this topic we will cover the anatomy and the physiology of the cornea, and one is the important clinical topic is the infective keratitis. So anatomy of cornea. As we know that the cornea is the part of the outer fibrous layer of the eyeball. The outer fibrous part of the eyeball, cornea is one of its main part. So it is the most important refractive medium of the eyeball. So it has the refractive power 44 diopters or 40 to 46 diopter is the range, and the refractive index is 1.376. And now the radius of curvature. The radius of curvature, the cornea has two parts, the anterior surface and the posterior surface. The anterior surface has the radius of curvature 7.8 millimeter and the posterior surface 6.5 millimeter. And the thickness. Now the thickness. See, this is the two surfaces of the cornea. The central part has the less thickness, so it has 450 to 500 microns thickness, and the peripheral part has the more thickness. It is 700 to 900 microns. Now the dimensions. The anterior surface is elliptical, so it will have two diameters. One is the horizontal diameter and one is the vertical diameter. The horizontal diameter is 11 millimeter and the vertical diameter is 11.7 millimeter. And the posterior surface is circular, so it has only one diameter. It is 11.7 millimeter. The shape is prolate. It means that the central part is more curved as compared to the peripheral part. The peripheral part is less curved. This type of shape is called prolate. Now the structure of the cornea. The cornea has the following layers. It has the epithelium, the Bowman's membrane, and the stroma, Descemet's membrane, and the endothelium. Now we see the epithelium. Epithelium is stratified squamous non-keratinized epithelium. It has 4 to 6 layers. The basal has the columnar cells. Then we have the wing-shaped cells and then the flat cells. The flat cells are with the microvilli. So the tight adhesions are present between these cells. Now the Bowman's membrane. The Bowman membrane is the most condensed part of the stroma, and it is derived from the stroma, and it is the most condensed part, and it is made up of type 1 collagen and no regenerative potential. For example, if there is injury to the epithelium, it has the regenerative potential. It can heal without scarring, but as the Bowman's membrane has no regenerative potential, so if there is any injury to the Bowman's membrane, it will result healing by the scarring. And now the third layer is the stroma. It is the thickest layer of the cornea, and it has the collagen fibrils. Then the ground substance, and these are called the keratocytes. The regular arrangement of the collagen fibrils is important for the collagen fibrils in regular orientation results in the transparency of cornea. So if there is any injury to the stroma which results in melting or dissolution of the stroma, so the collagen fibrils lose their orientation and it results in the corneal opacity. Then we have the Descemet's membrane. Descemet's membrane is the toughest layer, and it is also of the type 1 collagen. Some books says that there is also a Dwas layer, which is the pre-decimates layer. Now the last one is the endothelium. The endothelium is has the sodium potassium ATPase pumps, and due to these pump, it pumps the water out of the cornea. It results in the dehydration of the cornea and maintains the corneal transparency. If there is no water dehydration, it will result in corneal opacity. And it is a single layer of the hexagonal cells. The endothelium has the single layer of the hexagonal cells and most metabolically active layer due to the presence of the sodium potassium ATPase pump. So now what are the factors of the corneal transparency? There are the following factors which maintains the corneal transparency. One is the avascularity. There is no blood vessels present in the cornea. So any chronic disease which results in the formation of blood vessels from the limbus into the cornea results in the corneal opacity. And then the regular arrangement of the stromal lamella. The stromal lamella has the regular arrangement of the collagen fibrils, and it results in the corneal transparency. Relative dehydration of the cornea, and it is maintained by the endothelial pump. Then unmyelinated nerve fibers. There are the cornea has the unmyelinated nerve fibers. There is no presence of the myelin sheath, and it results in the transparency of the cornea. Then epithelium and the tear film. It provides the smooth optical surface and results in transparency of the cornea. Then the important topic is the infective keratitis. The infective keratitis can be due to the bacteria, fungi, viral, and Xanthomeba keratitis due to the amoeba. So due to the bacteria and fungi, we have the bacterial corneal ulcers and the fungal corneal ulcers, and due to the viral, we have the herpes simplex virus and herpes zoster ophthalmicus and Xanthomeba keratitis. So due to the presence of the epithelium, normally these infectious agents cannot enter into the cornea and infect it, but there are certain factors which can lead to the perforation of the corneal epithelium and results in the formation of corneal ulcers. One is corneal abrasion, then dry eyes. Dry eyes decrease the regenerative capacity of the epithelium. Contact lens misuse, prolonged steroid use, misuse of anesthetic drops, and neurotrophic keratopathy. It results due to the neurotrophic keratopathy, there is loss of the corneal sensation, and if there is loss of corneal sensation, it can lead to the corneal abrasion. Exposure keratopathy in legophthalmos, in which there is no closure of the eyelid and there is more exposure. It results in the exposure keratopathy, and due to the proptosis it can also result. Then immunosuppression and uncontrolled diabetes mellitus. These factors results in the damage to the epithelium, and due to damage to the epithelium, these infectious agents can enter the cornea and results in the formation of corneal ulcers. Now the bacterial and the fungal corneal ulcers. What are the symptoms? Symptoms are pain, redness, and lacrimation, decrease in vision, photophobia, intolerance to the light, and there is history of trauma with the vegetative matter. It is most common in the fungal corneal ulcers, and it is commonly in farmers during the harvesting season. Now we will see the bacterial corneal ulcers. The symptoms are pronounced. It means that there will be redness, pain, lacrimation, decrease in vision, and photophobia. And the signs are Single corneal ulcer. This is a single corneal ulcer with well defined distinctive margins. The margins are well defined and the base is the clean. The hypopyon. Hypopyon is sterile and mobile. The hypopyon is also present but it is sterile. If we drain the hypopyon, there will be only pus cells, no presence of the bacteria. And it is also mobile. It means that shifting the head moves the pus. If the patient moves the head, it will result in the movement of the hypopyon. And if we do the corneal scraping, and then if we scrap the cornea and then we do the gram stain and culture in the blood agar for the confirmation of the infectious agents. What is the treatment of the bacterial corneal ulcers? The fortified antibiotics eye drops or ceftazidime, it's 5%, and atropine eye drops. Atropine, why do we need the use of atropine eye drops? Because it is cycloplegic. Due to the bacterial corneal ulcers, the ciliary muscle spasm occurs, and if we use the atropine eye drops, it is cycloplegic. It will release the corneal ciliary spasm and relieves the pain. Then the fungal corneal ulcer. It is the single lesions. It can be single lesions or satellite lesions. Are single large lesions and small surrounding lesions. And the surface is dry and leathery, and hypopyon is non-sterile and fixed. Moving the head cannot move the hypopyon, and non-sterile means the fungal hyphae grow in the anterior chamber. And the margins are fuzzy, indistinctive. The margins are like indistinctive. Symptoms are less pronounced than the signs. So the signs are more prominent, but the symptoms like redness, lacrimation, pain, photophobia are less pronounced. If we do the corneal scraping, then we need the KOH mount and support dextrose agar for the confirmation of the infectious fungi. And what is the treatment? Treatment is natamycin 5%, because the most common organism of the fungal corneal ulcer is Aspergillus, and Aspergillus is sensitive to natamycin. And we also use the voriconazole, it is 1%, and atropine eye drops because it is cycloplegic and relieves the pain. What are the complications? Complication is the thinning and bulging of the cornea. Thinning because if the stroma melts due to the fungal corneal ulcers, then the cornea bulge out, and the Descemet's membrane, which is the toughest membrane, it will bulge out and it results in the formation of descemetocele. It is called descemetocele. And how we treat the descemetocele? We use cyanoacrylate glue over the dried wound, and then we use the bandage contact lens. And if there is, due to the fungal corneal ulcer, the perforation of the cornea occur, then we do the penetrating keratoplasty, corneal transplantation. If the cornea is ruptured, perforated, then we need to do the corneal transplantation, which is called as the penetrating keratoplasty. Then corneal opacity due to the healing. If the cornea heals, then there will be the corneal opacity. These are the complications. One is descemetocele, second is perforation of the cornea, and the third is corneal opacity. So the corneal opacity results after the healing. So we have the following types of the corneal opacity. Number 1 is called nubular opacity. It involves only less than 1/3 of the thickness of the cornea. If it involves 1/3 to half thickness, it is called as the macular opacity. If it involves greater than half to the full thickness, it is called leucomatous opacity. And if the lamella is adherent at the perforation of the cornea, it is called adherent glaucoma. So the corneal opacity, nubular, if it is 1/3, macular 1/3 to the half, and leucomatous half to the full thickness, and adherent the lamella attached at the perforation. This is the clinical representation. This is the nubular. It involves the 1/3, and if in this the iris behind it is visible and the details are also clear. But in macular, which is involving half of the cornea, the iris behind is visible but the details are not clear. And the leucomatous, which is involving half to the full thickness, the iris behind the opacity is not visible, and it results in the maximum vision loss. But in the nubular opacity, there is maximum visual disturbance because due to the scattering of the light. And the last complication is anterior styphyloma. If the perforated corneal ulcers occur, there is the protrusion of the outer coat with incarcerated uveal tissue. This is the anterior styphyloma. If the cornea ruptures and there is incarcerated uveal tissue also bulges out. Now, due to the virus, the herpes simplex virus keratopathy. In the primary infection, it is mild and subclinical, but in the OPD, the cases are due to the recurrent infections or secondary infections. So we see the epithelial keratitis, necrotizing stromal keratitis. These are the types of the herpes simplex virus keratitis. If it is involving the epithelial, it is called as the epithelial keratitis. If it is involving the stroma, it is called necrotizing stromal keratitis. If it is involving decimates membrane, it is called disciform keratitis, and if it is involving endothelium, it is called endothelial keratitis. And there is also last type, it is called neurotrophic keratopathy, and it is the inactive form of the disease. These are due to the active form of the disease. And the last one, neurotrophic keratopathy, it is due to the inactive form of the disease. Epithelial keratitis. Number 1, if the herpes simplex virus is affecting the epithelium, active viral replication results in the invasion of the epithelium. So we have the punctate keratitis, in which small punctate are formed on the cornea, and we have the dendritic ulcers. It is like a branching tree with the terminal bulb. And geographic ulcers, if the ulcer is involving a large area, it is called as the geographic ulcer. So this type of herpes simplex epithelium keratitis can be seen with the fluorescein dye and cobalt filter blue light. What is the treatment? Acyclovir 3% is the treatment for this, and it is most commonly comes in the OSP exam. So now the stromal keratitis. If the herpes simplex virus infecting the stroma, if it is the immune reaction to the viral antigen, there is the stromal edema, necrosis and the melting of the stroma, and anterior uveitis may be present. Topical steroids and oral acyclovir cover is the treatment. So this can be seen like the stroma is involved, so there will be the stromal edema. In disciform keratitis, it is the immune reaction to the viral antigen, same as the stromal keratitis. Stromal edema present and decimates fold. This is the important. Decimates folds are present. Keratic precipitates also present. So the treatment is same. Topical steroids under the cover of oral acyclovir. So see, in disciform keratitis, the decimates folds are present. Now the endothelial keratitis, the herpes simplex virus affecting the endothelium. It is also the immune reaction to the viral antigen. Endothelial plaques are present and dense decimates folds. Corneal edema with epithelial bullae. The stromal, the corneal edema is present and then the epithelial bullae are also present. Now the last one is the neurotrophic keratopathy or metaherpetic ulcer. It is the inactive form of the disease, and loss of the corneal sensation causes failure of epithelialization. If there is loss of the corneal sensation, there will be no epithelialization. The epithelium fails to regenerate and there is persistent and non-healing epithelial defect, which results in the opacification and thinning of the stroma. What is the treatment? The treatment, we use the lubricants. So due to the use of lubricants, we can enhance the epithelialization process and lid trapping at night. Then with the tape we closes the lid, and if the lid is closed, the tear film cannot be evaporated and results in the epithelialization. Then bandage contact lens and tarsography. It's like the suturing of the upper and the lower lid at the lateral side. If the this, for example, this is the eye, so we suture the upper and the lower lid at the lateral side. So it results in the protection of the tear film. Now the herpes zoster ophthalmicus. It is also due to the herpes varicella zoster virus. The virus lies dormant in the trigeminal ganglion, and if there is weakened immunity, it results in the reactivation and travels to the ophthalmic branch of the trigeminal nerve, and it can involve one or more divisions of the ophthalmic nerve. The frontal nerve, if it involves the frontal nerve, which is the most commonly involved, vesicles formed on the forehead, and if the nasociliary nerve, ocular movements involved. What are the symptoms? So the prodromal pain along the dermatome of the involved nerve. If it is involving the frontal nerve, there will be pain at the vesicles formed on the forehead, and if it is involving the nasociliary nerve, there is the eye, ocular movements are affected. Then the burning sensation, rash, fever. What are the signs? The vesicular rash at the scalp, forehead and the eyelids, and the Hutchinson signs. It involves the lesions at the tip and the sides of the nose. And what are the ocular signs? The ocular signs are the blepharitis, conjunctivitis, and episcleritis, and the scleritis, and epithelial keratitis. Uh, Epithelial keratitis can be punctate keratitis and pseudodendritic. It is not the true dendritic in which the terminal bulbs are present, but in pseudo dendritic there are no bulges present. Disciform keratitis, endothelial keratitis if it is involving the trabecular meshwork, so the trabeculitis and raised intraocular pressure, and anterior and posterior uveitis. So these are the ocular signs, and these are the vesicular rash and the Hutchison signs. So we can see three signs: vesicular rash, Hutchison signs, and the ocular signs, in which there will be like inflammation of the eye structures. What is the treatment? In herpes zoster ophthalmicus, we use the acyclovir 800 mg 5 times a day for the 7 to 14 days, and valacyclovir can also be used as 1000 mg 3 times a day for 7 to 14 days, and appropriate local therapy. Now the last one is acanthamoeba keratitis. It is due to the amoeba species. It is mainly due to the contact lens misuse. If the contact lens are not washed with the solution but washed with the tap water, it results in the acanthamoeba keratitis. The symptoms are out of the proportion to the signs. The signs are like the signs are present, but the pain is more severe. So what are the signs? We can see the dendritic ulcer, and the dendritic ulcer can form the ring ulcer and limbitis and keratoneuritis, and the inflammation of the corneal nerves. In the keratoneuritis, it results in the inflammation of the corneal nerves causing pain, and it is the most painful corneal ulcers, which is if the acanthamoeba keratitis affects the corneal nerves. In the corneal scraping, we use the calcofluor white stain and non-nutrient agar induced with E. coli. So we do the corneal scraping, and then we use the calcofluor white stain to identify the species, and we can culture in the non-nutrient agar enriched with E. coli. What is the treatment? BHMP, polyhexamethyl biguanide eye drops. This is the drug of choice, and the propamidine isethionate eye drops are also can be used. So this is the topic of the cornea.